welcome to the last session, Epigenetics Now or Never. And my co-moderator, Kelley from UCSF, will introduce the last speaker in this round. And I will introduce the first three. We are unfortunately heavily COVID-19 hit in this session, and the first three are recorded, and they will not be live either. And the last is live streaming, but not present among us here in the room. So the first three, we will go in one fast swoop through all their talks, and then we will go to the last one who is waiting to give the talk live. So the first talk we will see is from Ghassan Abou Alfa from the Memorial Sloan Kettering Cancer Center on alterations in germline alterations in the BTC, previously unappreciated and possibly targetable. And then we will go to Maeve Lowery from the University of Dublin in Ireland on targeting IDH version 2.0. Then we will go to Stephanie Roessler from University of Heidelberg in Germany, who will be presenting is the epigenome a driver of cholangiocarcinoma. So please put all three talks up one after the other. Thank you.
Thank you again for the invitation, and congratulations for the Cholangiocarcinoma Foundation on this year's meeting. A greatly honored to join you here today on Thursday and talk about, and let me share my screen, the germline alterations in biliary tract cancers. Truly previously underappreciated and of course possibly targeted. These are my disclosures. And these are my contacts. Please feel free to take any information you like or copy the QR code on camera, and you can connect with me, and more than happy to discuss anything related to research, medical, or educational points. So with this said, a lot of efforts have been done, including the one here at Memorial Sloan Kettering, where we looked into the germline for biliary tract cancers. And in a small series, about 131 patients, we found that the median age was about 59, and intrahepatic cholangiocarcinoma made most of the patients, about 64%, while equivalent number between gallbladder cancer and extrahepatic cholangiocarcinoma. The most important, though, is that the pathogenic germline alterations were noted at a median age of 53, even younger, and altogether, there were about 16% of the patients, and they were rather equivalent in incidence among the three types of diseases, maybe relatively a tad more in regard to gallbladder, followed by extrahepatic cholangiocarcinoma, and finish with intrahepatic cholangiocarcinoma, ranging between 14 and 18%. However, more importantly, 10% were high to moderate penetrance in regard to post-cancer predispositions. This is a delineation that shows what are the genetic alterations that we have seen, and BRCA2 definitely was the driver, and most of them 24%. This is not the only effort. Other groups have done similar work, and we can see here the nice work by Dr. Lin and colleagues looking to the DNA damage repair. And in a cohort which was rather larger, 357 patients, the 26% had a mutation in more than equal to one DNA damage repair or DDR gene, and 15 were germline. And there was a higher tumor mutation burden subgroup as well, and at least this 25% patient had more than one actual alterations. Interestingly, that effort included also a therapy, and olaparib was given to 8 patients, and there were 3 partial responses and 2 stable diseases. Of note, the landscape of the DDR mutation frequencies was as expected, but here a nice comparison between hepatocellular carcinoma and intrahepatic cholangiocarcinoma, and as we know, both are diseases that affect the liver or the bile ducts within the liver. And we can see that the mutation frequencies were probably similar in incidence, but had, however, differed to some extent. And the aim is not here to compare, but to show that the basic excision Fanconi's, the homologous repair, and checkpoint factors were distributed in certain varied way in regard to intrahepatic cholangiocarcinoma. Another effort that, if anything, showed the same kind of findings, that the DDRs were noted in about 20 genes. Some of them were direct genes, among which, of course, the BRCA1 and 2, and caretakers, especially the BAP1. Tumor mutational burden, more than 20 mutations, was also noted. And we can see here a nice delineation of the DDR plus direct genes, caretakers, and TMB high based on the different type of diseases. And if anything, it knows, again, one more time, a very subtle difference between the types of diseases that we can delineate anything from. From Korea, no doubt that also it has been noted that BRCA mutations is evaluated in about 18% of the patients, and most commonly what is mutated DDRs. And there was an effort for therapeutic evaluation here, with 88 patients received first-line platinum therapy with a progression-free survival of 6.5 months and overall survival 16 months. And you can see over here that this kind of advantage was for the DDR plus patients compared to DDR minus, with a certain clinical and statistical significance. And by the way, the landscape was quite varied, as we can see over here, was, as usual, the kind of potential targets are similar to what has been reported by other groups, as we can see over here with the different drivers per se. Now, in regard to the caretaker genes, BAP1 come into play. This is beautiful work, and congratulations for Dr. Lamarca and colleagues on really explaining to all of us really the BAP1 kind of caretaker and key role in regard to any alteration of it will kind of, cause the remodeling or its absence altogether, or damage leading to predisposition for cancer-related diseases. And a beautiful example here about how the genetic alteration plus the caretaker genes interact. We can see over here that the base excision repair and homologous repair are important two parts that really drive into the BRCA and the PARP1. And understandably, we need the blockade to occur for both of them, as you can see to the extreme right, with a PARP inhibitor in the presence of a BRCA germline alteration to cause a cell death. Interestingly, and something to think of a little bit further, even though we don't have the full clarity, in a PARP inhibition use in a non-mutated BRCA, what will that mean? And this is something to yet understand better. To go back to the effort that I mentioned a second ago from Korea, we can see over here one more time the delineation in regard to the overall survival and the progression-free survival in Kaplan-Meier curve forms. And it's very important to illustrate that difference one more time visually to appreciate how critical it is to, as Dr. Shea and colleagues did present first-line platinum therapy. And of course, the effort is the nice work that was done by many of you who are present in the group today, was leading by Dr. Ghassan from Israel, looking into the PARP inhibition in biliary tract tumors. And as we can see here, the alterations were mainly, as we spoke already, BRCA2 and 1. And platinum-based therapy was given for 13 out of the 18 patients. And no doubt that the overall survival was markedly improved, understandably better in the stage 1-2 disease patients, but even in stage 3 and 4 disease, 25 months. And of course, this work is still ongoing. If anything, I'm giving snippets of the whole story, but the nice work is already ongoing, with the nice work done by Dan Ann and Milind Javli in regard to the single-arm phase 2 trial of olaparib, with the patient with any of the germline or the caretaker genes eligible. And there's another effort by Dr. George also looking into niraparib for the BAP1 tumors as well. We'll await for all this data, but if anything, at least some reflection at this point in time that about a quarter of the patients with biliary tract cancer have DDR positive. And the question is there survival advantage? Number two is the platinum now the standard therapy plus PARP inhibitors in development? And of course, we'd like to see, similar to pancreatic cancer, some further evolution of this effort in regard to biliary tumors. Intriguingly, and there are some kind of components about the IDH1 mutation patients, which, as we know, can probably encompass about 15-20% of the enterprise cholangiocarcinoma, which Dr. Lowery is going to nicely talk about next. And we can see clearly here that there's a certain possibility of preclinical models suggesting that mutated IDH1 dependent PARP inhibitor sensitivity. So this is something to yet understand better, and especially not only for the IDH1, but for the other genetic alteration like FGF and what have we. What about Ddr and immunotherapy? And this is especially very pertinent, especially in the advent of the gemcitabine cisplatin plus durvalumab based on the Topaz one study that showed a critical improvement in survival for adding on the durvalumab to the baseline gemcitabine cisplatin. And already, as many of us know, has become a standard of care that many of us are using. Now, I will take this discussion even one step further. And if anything, over here in northern India, the germline BRCA1 and 2 were delineated and reported by the group in India, showing the different genetic alteration variants of it. And interestingly, a similar effort was done in Pakistan, again, mainly in regard to northern Pakistan, and we can see the genetic alteration happen. And if you were to kind of like look at those two maps, you'll see suggestive, probably some similarities. This is especially true, but because when we go all the way to East India, you'll see that the 185 deletion AG and the 6174 deletion T were not noted, and they were absent. And the question is, are the genetic alterations, of course, driven by where people live and what their ethnicity is, and the Kashmir area, despite the war separation, could probably lead to the same alterations on either side of the border. The same thing applies, by the way, to many other efforts. One of them, to give credit, which was done and evaluated among the Jewish Israelis and as well as the Arab Israelis. And we can see here that a certain perspective of more ovarian cancer among the Muslim Arab Israelis, or the Palestinian of 1948, as we call them, versus the Jewish Ashkenazi Israelis had breast cancer. Of note, similar effort was delineated because of the connectivity in that area of the world among the populations, and BRCA1 and 2 mutations are noted among different groups. As you can see over here, they are very well clearly noted among the patients in Lebanon, and we can see the different variations, especially at young age group. As such, a great effort that we are currently ongoing at Memorial Sloan Kettering, looking at humanity cancer germline conversions and diversions. We finished our first effort, thanks to our colleagues literally from all over the world, as you can see here, delineating all the countries that have joined us. And of course, you'll hear more and more about this effort as time goes. As such, I can conclude that germline inherited cancer susceptibility as a cancer, as a cause of mortality and morbidity, is among different ethnic groups worldwide is well noted. A better understanding of the genetic variances may help define the appropriate and most adequate screening and treatment modalities for the best applicable to specific populations. And the framework for collaborative research worldwide, including areas of conversion divergence, is important, especially in conflict areas. And international cooperation is very critical for that purpose. And this is really what we should go all do together. I thank you all, and I pass it back to the chair. Thank you for having us.
So good afternoon. I'm Maeve, a medical oncologist in Dublin, Ireland, and I'm delighted to speak to you this afternoon about developments in therapeutic targeting of IDH mutant cholangiocarcinoma. Thank you to the chairs for inviting me to speak, and I'm sorry I'm not there to enjoy the conference in person this year. And these are my disclosures. So by way of brief background, IDH stands for isocitrate dehydrogenase. IDH1 is cytosolic, IDH2 is mitochondrial, and these both have similar function and sequence. Wild-type IDH is a key component of the TCA cycle, And the IDH1 and 2 enzymes catalyze the interconversion of isocitrate and alpha-ketoglutarate. IDH1 or 2 mutations typically occur at catalytically active sites, and mutant IDH1/2 alters enzymatic activity. So it reduces alpha-ketoglutarate to the alkyl metabolite 2-hydroxyglutarate, or known as 2-HG. So this is a gain of function or neomorphic alteration. And 2-HG accumulation competitively inhibits alpha-ketoglutarate dependent enzymes. So IDH1 or 2 gain of function mutations lead to accumulation of the alkyl metabolite 2-HG. And 2-HG promotes carcinogenesis through disruption of multiple key pathways, including cellular metabolism, epigenetic regulation, and DNA repair. And mutant IDH1 also creates a heterodimer with wild-type IDH1, reducing alpha-ketoglutarate concentration, increasing HIF1 alpha, and then promoting also angiogenesis. So IDH1 mutations occur in about 15 to 20% of intrahepatic cholangiocarcinomas. They're much less common in extrahepatic cholangiocarcinomas or distal bile duct cholangiocarcinomas, and also less common in cholangiocarcinoma associated with liver fluke or with hepatitis. IDH R132C and R132G are the most common mutations, and these infrequently co-occur with alterations in FGFR2, the other main targetable molecular alteration in cholangiocarcinoma. And when we look at the patterns of co-mutations in somatic mutational profiling of cholangiocarcinomas, you can see distinct patterns of mutual exclusivity and co-mutations in mutant IDH cholangiocarcinoma. In particular, mutually exclusive pattern with IDH1, and also more rarely co-mutated with KRAS. So multi-omic analysis of IDH mutant cholangiocarcinomas has shown characteristically a low expression of chromatin modifiers, but an elevated expression of mitochondrial genes and also increased mitochondrial DNA copy number. And in this integrated whole genome and epigenomic analysis of cholangiocarcinoma, IDH1 mutant tumors were associated with hypermethylation. And you can see here in cluster 1, which was a hypermethylated cluster enriched in fluke-positive cholangiocarcinomas, is actually dominated by hypermethylation in promoter CpG islands, whereas cluster 4, which is enriched in fluke-negative but enriched in IDH mutant cholangiocarcinomas, is dominated by hypermethylation in promoter CpG island shores. And so showing the distinct patterns of hypermethylation within IDH1 mutant cholangiocarcinomas and a distinct phenotype. So establishing therefore that IDH mutant cholangiocarcinomas are a distinct phenotype characterized by particular characteristic alterations and a hypermethylated pattern, they obviously are a particular subgroup ripe for analysis and evaluation in prospective clinical trials on a molecularly selected population basis. And this has been a very successful year for development of targeted therapeutics for IDH mutant cholangiocarcinoma. Of course, you'll all be aware of the recent approval by the FDA of ivosidenib, mutant IDH1 inhibitor. And that was based on results of the Clarity study and final overall survival results of which were presented recently. So Clarity study was for those of you less familiar, a randomized phase 3 study. It involved patients with advanced cholangiocarcinoma with centrally confirmed IDH1 mutation by next generation sequencing. Well patients, you got performance status of 0 or 1, and patients could have had up to 1 or 2 prior therapies and had to have had a gemcitabine or 5-FU containing regimen. So patients were obviously pre-screened for the presence of the IDH1 mutation and then randomized in a 2-to-1 double-blind placebo-controlled fashion to ivosidenib or placebo, and crossover was permitted at radiographic disease progression. Primary endpoint was progression-free survival, and secondary endpoints, of course, safety and overall survival. So the baseline characteristics were really well balanced between the two groups, and the R132C mutation, as expected, was the most commonly identified one. All patients who got performance status 0 or 1, and as expected, dominated by intrahepatic cholangiocarcinoma. So the final overall survival analysis really showed that ivosidenib improved overall survival by almost 3 months when compared with placebo in pretreated patients. And according to this final analysis, the median overall survival was 10.3 months for patients in the ivosidenib arm and 7.5 months for those in the placebo group, showing a numerical but not quite statistically significant benefit. But due to crossover, analysis was performed using this pre-specified rank-preserving structural failure time analysis to adjust overall survival. And in this specific analysis, the adjusted overall survival was 5.1 months for cholangiocarcinoma patients receiving placebo. And so this made the overall survival benefit of ivosidenib significant in this particular pre-planned analysis with a hazard ratio of 0.49, a significant p-value. Looking at the progression-free survival results, then you see a small but significant improvement in median progression-free survival. But more noteworthy is the 6-month progression-free survival rate of 32% and 12-month progression-free survival rate of 22%, with no patients progression-free in the placebo arm at 6 or 12-month landmark analyses. And disease control rate, of course, a small response rate, just 2%, mirroring what we saw in the phase 1 study of a low response rate, but improvement in disease control rate as compared to placebo. So evidence of clinically meaningful efficacy in these results. And this was seen across all subtypes, intrahepatic versus extrahepatic, across both sexes, male and female, and interestingly, regardless of number of prior lines of therapy. So looking at the final conclusions of the Clarity study, we see about 70% of patients on placebo were able to cross over to active treatment. That adjusted survival analysis acknowledging that, that there was crossover permitted, showing, implying a more significant overall survival benefit than seen in the unadjusted analysis. There was some improvement in health-related quality of life, and study met its primary endpoint of progression-free survival. And I suppose a very important observation on the Clarity study is that we can do randomized placebo-controlled studies in rare malignancies. The study design is feasible and can be done and should be done to demonstrate the evidence that is required to achieve FDA approval or authorization for a particular targeted agent. So a really exciting year for the development of targeted therapies for IDH mutant cholangiocarcinoma. I suppose many questions still remain, and we still have some way to go in finessing the development of therapeutic targeting of mutant IDH and cholangiocarcinoma. So what key questions remain? Well, it's clear from both the phase 1 and the phase 3 studies in ivosidenib targeting of cholangiocarcinoma, the mutant IDH1 is required, but not sufficient for response to the targeted agent, and we do need additional biomarkers. So certain patients who have a more prolonged and durable disease control, and other patients who appear to have much less of a response to almost no response to the agent, yet all patients' tumors contain the biomarker of mutant IDH1. So why is that? And we still poorly understand that. What are the mechanisms of primary and secondary resistance? So I'll show you a little data in a few moments that gives us some ideas of what those might be, and they need to be better clarified so we can develop next generation strategies for overcoming these resistance mechanisms. What is the role of co-mutations? There are additional subgroups that we should be looking at to optimally select the patients who benefit from this targeted approach. And of course, what's the optimal sequencing and combination with cytotoxic chemotherapy, with immunotherapeutic agents, and with other targeted agents? And I suppose importantly, how do we move beyond single agent IDH1 or 2 inhibition in cholangiocarcinoma, and what additional therapeutic strategies do we have for this particular molecular subtype of cholangiocarcinoma? So regarding co-mutations, I suppose the short answer to that is this was looked at in the phase 1 trial, which incorporated many translational endpoints, and really there was no clear pattern seen of association of co-mutations with progression-free survival or response in that patient population. That was a very large phase 1 study with a lot of tissue and blood samples provided for analysis. So still an open question as to whether additional co-mutations could impact upon the response, but certainly on panel-based testing, no evidence that there is a particular pattern of co-mutations associated with that. More interestingly, I suppose, from translational analyses from the earlier phase studies of ivosidenib in mutant IDH cholangiocarcinoma, we have gained a bit of an understanding as to the mechanism of action of IDH1 inhibition in IDH mutant tumors. And this study, published just last year, was based on samples taken in the phase 1 clinical trial, which were paired samples at baseline at cycle 3 of treatment. And gene expression analysis was performed in these matched sample pairs. And this allowed, I suppose, an analysis of what key pathways and transcriptoma changes occurred within the tumor in terms of exposure to treatment, and allowed correlation of those findings with progression-free survival and response. So what was found was this increase, in particular, in a cholangiolar pattern and a decrease in cytoplasm following treatment with ivosidenib. And these are biopsies at screening and 3 months post-dose. So that's 2 separate patients, first and bottom, and you can see that particular change in pattern in the cholangiolar pattern of the disease. And importantly, in transcriptomic analysis, ivosidenib induced expression of liver-specific genes and decreased cholangiocyte lineage markers. And looking at those decrease in cholangiocyte lineage markers, they were found to decrease with treatment. That's CK19, EpCAM. And there was also found to be a trend in improved progression-free survival in cases of cholangiocarcinoma that acquired a cholangiolar pattern, some kind of a sense, acknowledging from a phase 1 study only that we see the cholangiolar pattern implying a response or a benefit for patients, and remembering that the response rate in these studies was very low, perhaps a hint that this mechanism, in fact, would infer a clinical benefit to a patient in the absence of a radiographic partial response by RECIST criteria. So these changes induced by IDH1 inhibition sort of included morphologic changes towards hepatocyte differentiation, with hepatocyte differentiation then seeing a decrease in markers of biliary fate, cell cycle progression, stemness, and decrease in AKT pathway activity. In patients who had more rapid progression, more of an increase in AKT activity, cell proliferation, and stem cell signatures. And so looking as though perhaps in patients with disease control treated with ivosidenib, there was an induction of differentiation of cholangiocarcinoma cells towards a hepatocyte-like phenotype, at least in these patients who had potential benefit. So that understanding perhaps, or suggestion of a particular mechanistic explanation for why certain patients might respond, or at least selecting out the mechanism by which they do respond, may assist us in better refining selection of patients for such an approach and optimal therapeutic combinations. So we mentioned about mechanisms of primary and secondary resistance and the importance of delineating these to develop new rational combination strategies to overcome this. And one very interesting observation, again from the phase 1 study, was the phenomenon of isoform switching as a mechanism of resistance to ivosidenib. So this demonstrates here a patient treated on the phase 1 clinical trial who had a biopsy taken pre-treatment at progression of one lesion and subsequent progression following treatment beyond progression at beyond a year. Patient who had a significant benefit and was treated for a long time on study. And the lower panel D here, the circulating tumor DNA analysis by digital PCR of the initial R132C mutation, which was the mutation present in tissue at time of patient enrollment to the study. I suppose what became evidence in sequencing of blood and tumor samples from the patient throughout progression was the emergence, which occurred at the same time, of subsequent disease progression of an IDH2 mutation. And of course, mutant IDH2 is the only other mutation that could produce the alpha metabolite 2-hydroxyglutarate. So evidence that as there was suppression of the IDH1 R132C mutation by the ivosidenib, that there was an emergence of R132C, IDH2 mutation R172V as a mechanism of secondary resistance. So this isoform switching as a mechanism of resistance in IDH1 mutant disease. And this was also seen a subsequent patient treated in the IDH1 phase 1 study demonstrated that after post-dose treatment within the tumor somatic analysis mutation profiling in tumor tissue, that an initial R132C IDH1 mutation present in the tumor, and then subsequently R132C not detected but converted in fact, to IDH R132F, which is a much lower sensitivity to inhibition by ivosidenib as compared to R132C. So some ideas of how we perhaps can identify these mechanisms of resistance and perhaps develop strategies for overcoming. So moving beyond IDH inhibition alone, there's, I guess, additional characteristics of mutant IDH cholangiocarcinoma that can potentially be targeted, and the DNA damage response pathway is one very promising one. So I guess genomic instability and altered metabolism are common characteristics of tumor cells, but not much crosstalk between these processes has really been reported so far. And this study, published a few years ago now, showed that essentially cells that did not have high levels of oncometabolites, including 2-hydroxyglutarate, had a sort of spike in following induction of double-strand DNA breaks of H3K9 modifications locally in the chromatin in the vicinity of the double-strand break within 30 minutes of it being induced. And that was followed by this coordinated recruitment of factors needed for homologous recombination repair. However, in cancer cells which had higher levels of oncometabolites, including 2-hydroxyglutarate, this was elevated throughout the genome before double-strand break even induction, and subsequent recruitment of factors that are needed for homologous recombination repair was impaired compared to those in the control cells. So this implies that one could perhaps exploit the DNA damage repair pathway for therapeutic intent in IDH1 mutant cancers. And this study, a preclinical study, showed that ATR, so telangiectasia and RAD protein kinase related proteins inhibitors, are active against IDH1 2 mutant cells. And this activity was further potentiated by a combination with PARP inhibitors. So an ongoing phase 2 clinical trial is investigating this combination of the anti-tumor effect of a PARP inhibitor, olaparib, in combination with ceralasertib in IDH mutant solid tumors, including cholangiocarcinoma. So I suppose giving us perhaps evidence that combination therapies could enhance synthetic lethal interactions in IDH mutant tumors. Other potential therapeutic strategies looking at interaction between the oncometabolite and the immune microenvironment of the tumor. So some studies here, this is from the TCGA and clinical sample and gene expression data, demonstrate, I guess, reduced expression of cytotoxic T lymphocyte associated genes and interferon gamma inducible cytokines in IDH mutant tumors compared to IDH wild type tumors. And this also expression of mutant IDH1 reduced the accumulation of T cells within tumor sites. And this suggests a mechanism of immune evasion in mutant IDH cancers and implies that specific inhibitors of mutant IDH may perhaps improve the efficacy of immunotherapy in patients with IDH mutant tumors. So where are we going from here? Where are the new studies, the new clinical trials that are currently active? I suppose a select number, and some to point out, we have, I suppose, the obvious combination of ivosidenib plus cisplatin gemcitabine as first-line treatment in patients with metastatic disease. The dose de-escalation phase 1 study already underway there. Phase 1 study evaluating combination of nivolumab with ivosidenib in advanced tumors with IDH1 mutations, including cholangiocarcinoma. And then, of course, several newer IDH1 inhibitors under evaluation. So FT2102, assessing a phase 1/2 study with IDH1 mutant tumors, and a subsequent patients will receive potentially following the initial dose assessment phase, either the experimental treatment or cisgem reference doublet. So a large study to enroll almost 200 patients. So I guess a successful year in development of therapy for IDH mutant cholangiocarcinoma. Many areas to explore in terms of potential future therapeutic targeting, even beyond single agent IDH1 inhibition, and development of new and next generation IDH1 inhibitors ongoing and currently under evaluation. So to conclude, I suppose we've had success this year in targeting mutant IDH1, our first FDA approval of an agent for this particular select population. We still have much to do. I do think addressing and identifying primary and secondary resistance mechanisms are key to developing new strategies. And multinational collaborative efforts are essential, and particularly with clinical trials incorporating translational endpoints. You see the wealth of information we gained from those translational endpoints, even on the phase 1 study. But to conclude, I suppose this has always been a meeting full of forward-looking, optimistic, enthusiastic clinicians and researchers and patients and advocate. So I thought I'd leave you with this uplifting quote from one of our famous Irish poets, Seamus Heaney, and a lovely picture, of course, of Ireland.
Hello, everyone. I'm very happy to present today to you does the epigenome drive cholangiocarcinoma? And I would like to thank the organizers for inviting me to give a presentation here today. Epigenetic alterations are very common in different cancer entities, and they can be at various levels. So besides the histone modifications, there's also variants of RNA interference by non-coding RNAs affecting protein expression and of course also DNA methylation. And recently, the epigenetic alterations were also added to the cancer hallmark. Epigenetic marks are also interconnected with different metabolites as shown here. So for example, the methylation is affected by methionine and succinate and fumarate and alpha ketoglutarate. But also other metabolites of the Krebs cycle are involved, and also glycosylates is heavily involved in different aspects of epigenetics. So it's a crosstalk between epigenetics with the metabolome, with proteins, protein modifications, and also with non-coding RNA. Very interestingly, epigenetics is not a final state, but it is caused by a high plasticity. And for example, DNA methylation marks can be reversed, and they can be modulated at different levels. So also specific methylation marks can be changed during the course of cancer. And this allows for the selection of cells with the, so to say, driving forces for the cancer development. And this holds true for both the DNA methylation and also for the histone marks, and also for several other marks that are epigenetic. So due to the epigenetic plasticity, there's a high heterogeneity in the tumor. Coming now to cholangiocarcinoma, there is a high need to classify cholangiocarcinomas into different subtypes. We have, since long time now, the classification based on the localization of the tumor into intrahepatic cholangiocarcinoma and extrahepatic. And extrahepatic is further divided into perihilar and distal cholangiocarcinoma. Furthermore, intrahepatic cholangiocarcinoma was based on the morphologic, also subclassified into small duct type ICCA and large duct type ICCA. But even when looking here at these images, you can appreciate that there is further heterogeneity. And this heterogeneity is also caused by mutations and also epigenetic alterations. A study by TCGA used extrahepatic and intrahepatic cholangiocarcinomas to perform an integrative analysis. This analysis showed that IDH mutant cholangiocarcinomas have a very distinct pattern both on the DNA methylation, mRNA, and also at the genetic level. Furthermore, extrahepatic cholangiocarcinoma is very different, and also other non-IDH mutant tumors have different heterogeneity. So there are several groups of intrahepatic cholangiocarcinoma. And you can see this also here in this subgroup of BAP1 FGFR2 mutant tumors. There is still a high heterogeneity. So further subgrouping might help to classify patients based on the molecular alterations, and therefore might also aid the targeted therapy of cholangiocarcinoma. We performed integrative analysis of 52 intrahepatic cholangiocarcinomas and performed DNA methylation analysis as well as mutation analysis. Similarly to the TCGA study, we found that IDH mutant cholangiocarcinoma have very distinct patterns. These are classified here and have a distinct DNA methylation pattern. Interestingly, all these tumors were of the small duct type ICCA. The other two groups with low DNA methylation are called L for low and intermediate methylation groups. Another group, that's the fourth group over here, had also high DNA methylation alterations. Similarly, the level of the IDH mutant cases, but different sites were affected. So there are different DNA methylation patterns in the high DNA methylation group and in the IDH mutant group. All of the IDH mutant samples had hotspot mutations as shown here. And also when looking at the patient characteristics and the overall survival, we found that there are differences between these four subtypes. The best outcome had the group of the low alteration group. IDH mutant cases had intermediate survival, whereas the high and medium group, they had the worst outcome. So the different ICCA subgroups also differ in their clinical presentation, and this might be also relevant for therapy. IDH mutants are, as they are hotspot mutations, a good target for targeted therapy. And therefore, people have been looking at different inhibitors for IDH. So IDH mutants might have the benefit that all these cells have this mutation. However, there's still a lot of plasticity and there is an interaction between the tumor cells and the immune cells, leading to immune evasion, and therefore it has been proposed that IDH mutation inhibitors should be also considered in combination with CTLA-4 blockade. Furthermore, there is the question how really cholangiocarcinoma is evolving. And these early steps might be the driving steps. Therefore, we also looked at different precursor lesions. The biliary intraepithelial neoplasia, BILIN, have been proposed to be a distinct progenitor of invasive cholangiocarcinoma. Two other types are the intraductal papillary neoplasia of the bile duct, IPNB, and intraductal tubulopapillary neoplasia of the bile duct, ITPN. These are macroscopic lesions and have been proposed to lead to cholangiocarcinoma. To further characterize IPNB and ITPN, we collected samples and analyzed them based on the morphology and also on the immunohistochemistry in the ITPN and IPNB cases. Here are representative samples shown. Interestingly, ITPN and IPNB cases seem to have quite favorable outcome. This was also true when we analyzed IPNB and ITPN cases with associated cholangiocarcinoma of the UACC stages 2 and 3, and compared these to CCA cholangiocarcinoma, which are non-IPNB and non-ITPN. So no IPNB or ITPN was detected. And again, IPNB and ITPN cholangiocarcinomas, they had favorable outcome. When looking at the clinical parameters, we further found that IPNB are mainly localized in the perihilar or distal location, whereas the ITPN are mainly localized intrahepatic. So there might be a difference in the origin of IPNB and ITPN. The mutations in IPNB and ITPN also mirrored the mutations of extrahepatic and intrahepatic cholangiocarcinoma. For IPNB, we mainly found TP53, SMART4, and KRAS mutations, which are typically found in extrahepatic cholangiocarcinoma. ITPN had overall fewer mutations, and only one case had an IDH mutant. This case also had an associated intrahepatic cholangiocarcinoma of the small duct type. So this is also consistent with the anatomic location of IPNB and ITPN. Next, we wanted to confirm that IPNB and ITPN are really the precursor lesions of associated cholangiocarcinoma in the same patients. When comparing the mutations of IPNB and ITPN to the associated cholangiocarcinoma, we found that indeed the same mutations were present, especially for P53, KRAS, and SMART4. However, other mutations were exclusively found in the invasive carcinoma. One of these mutations is a ROBO2 mutation. So we found that the non-neoplastic lesions proceeded via the precursor lesions to cholangiocarcinoma. They accumulated additional mutations, and most likely IPNB and ITPN are direct precursors of the invasive carcinoma. Looking now at the DNA methylation profiles, we found that the normal samples clustered very distinct, whereas the IPNB and ITPN clustered together with their associated invasive carcinoma, showing that they have conserved DNA methylation alterations compared to the normal bile duct epithelium. Since we have been using the triplet sample of the same patient, this is indicating that indeed the methylation changes that are accumulated in the precursor lesion are also staying in the invasive carcinoma. Furthermore, Thyssen plots revealed that ITPN and IPNB have differences in their DNA methylation. Looking also at Medicom analysis, we found that most likely IPNB and ITPN have different cells of origin. IPNB had different LMCs. These are components of different cell types, whereas ITPN had mainly the same LMC component, indicating that they have all the same cell of origin, which is different from IPNB. So in conclusion, we found that there are different ICCA subgroups, and these subgroups differ in their DNA methylation profiles, but also in their mutational profiles. And the alterations in the epigenetic profiles are indicating that these might be drivers of cholangiocarcinoma, at least in some of these patient subgroups. In addition, we found that IPNB and ITPN are distinct precursors of invasive carcinoma, and IPNB and ITPN may have distinct cells of origin. DNA methylation is a very powerful tool also to detect cholangiocarcinoma early on. This study focused on plasma in different patients, and they were able to predict extrahepatic cholangiocarcinoma compared to non-cancer patients. However, their prediction algorithm didn't work well in PSC patients. Another study looked specifically at PSC patients, and using other DNA methylation markers in the bile of patients, they were able to distinguish PSC patients with cholangiocarcinoma from patients without cholangiocarcinoma, but with PSC. So the combination of different markers and also maybe of different tools might aid in the early detection of CCA in patients at risk. With this, I would like to thank everyone involved in our cholangiocarcinoma efforts in Heidelberg, in München, and also in Düsseldorf. And I would like to thank you for your attention.
So it's my pleasure to introduce the final speaker of this session, who is joining us live. This is Dr. Li-Tzong Chen, who is a professor of gastroenterology and oncology, as well as an investigator and deputy director at the National Institute of Cancer Research in Taiwan. And he will be presenting today on novel epigenetic targets in the clinical setting besides IDH1. Thank you. And Chen.
Thank you, Mr. Chairman, for your kind introduction. Now I'm going to share my slide. And today I'm going to talk about the novel epigenetic targets in the clinical setting besides IDH1. Sorry. Okay, this is in the left side panel, actually that shows the genetic alteration in the patient with intrahepatic cholangiocarcinoma. In the right side panel, that is a recent publication that shows the molecular target agent that currently available, and some that have been tested in the cholangiocarcinoma. Some for the maybe more agnostic approach were not tested in cholangiocarcinoma yet. And for the cholangiocarcinoma, we can see most of the patients that have a molecular target agent is talking on the tyrosine kinase inhibitor, on the IDH1, IDH2 mutation, BRAF, or there were some of the patients may have a FGR fusion, or some may test it for the PI3K mutation. But for most of the patients with a genetic alteration, there's still some of the effective agent can be available. Can that the epigenetic therapy is one of the alternatives for other than direct targeting on the mutated gene? And since this recent publication that shows some of the molecular target agent for the epigenetic moderation current in development, that has been highlighted in red color. I think there were not so many. But in these past few years, actually there was some progress in the development of the compound and also some research done on cholangiocarcinoma that opens some of the new hope for the treatment of the cholangiocarcinoma with epigenetic moderators. This is the clinical study that lead to the approval of the IDH1 inhibitor in the patient with cholangiocarcinoma. Actually, you can see, although this compound have led to the prolongation of the median progression-free survival, but actually the tumor response rate was not so exciting. Only 2% of the patient got an objective tumor response, and another maybe 50% of the patient got a disease control. Overall survival, there is a slight improvement from the 9.7 months to the 10.8 months. So what else we can do? But actually, there was some very interesting preclinical data that may suggest the epigenetic agent, modulating agent, maybe have some help for this group of patients. In year 2016, there is a publication, actually the investigator using a panel of the cholangiocarcinoma cell line. Most of them were without IDH mutation. Only 2 cell lines had the IDH1 mutation. And they tested with a different molecular target agent and tried to develop what kind of the agent can be helpful for the IDH mutation patients. Actually, in their publication, they emphasize on the SUC dependence pathway. So they try to testing, there is a compound called the dasatinib, that is a SUC inhibitor. And they directly go to a clinical study, but unfortunately, in this phase 2 study of the dasatinib in patients with IDH mutated advanced intrahepatic cholangiocarcinoma, totally 8 patients were included, but there was no objective response were observed. But other than the so-called SUC pathway, there's a very interesting that were highlighted in the yellow box. You can see for the 2 tumors with the IDH1 mutation, we can see there is 2 compounds that belong to the so-called BET inhibitor. Actually seems to be quite promising in the IDH mutated tumors. And in 2018, actually, our Japanese colleague also repeated the study and found that the BET inhibitor ZQ1 can more effectively suppress the growth of the IDH mutated RBE cell rather than the IDH wild type cells, the HUCCT1 and also HUS28. If they try to transfer the mutated IDH1 into the tumor, HUCCT1 cell, then the cell can be effectively suppressed by the ZQ1. That suggests the presence of the IDH1 mutation can render the cell to be more effectively suppressed by the BET inhibitor. maybe years later, actually there is a study trying to use the BET inhibitor to treat that is a different kind of the cancers. And they did not select the IDH1 mutated tumor because the IDH1 mutation may be not so common in this kind of tumor. And they still can show that the the BET inhibitor also has been known to be effective to downregulate the c-MYC oncoprotein expression. So it can be a good agent for the MYC overexpression tumor. In the right side panel, actually, you can see that MYC over amplification has been noted in 3% of the Western population, but only in about 1% of the Chinese patient. So if a BET inhibitor can be effectively suppressed the IDH1, IDH2 mutated tumor, and also the MYC amplification tumor, then there's about 25% of the Western population can be treated with a BET if that can be proved to be effective. But in the Asian population, that only about 15%. So there is another study, actually, they try to test this BET inhibitor because it can regulate some of the oncoprotein or some of the DNA repair gene expression. So there is a study that shows that BET inhibitor actually can downregulate the homologous recombinant protein. And so that renders the tumor that more sensitive to the PARP inhibitor. So there is a synthetic liaison between the BET inhibitor and the PARP inhibitor. I think based on this observation, actually currently there are some very exciting clinical study from the AstraZeneca. They're using their AGT 5153 compound that is a BET inhibitor in combination with their olaparib. Try to have a phase 1 study. In that phase 1 study, actually is a 2-arm study. One is for the BET inhibitor alone. The other is a BET inhibitor plus the PARP inhibitor. And this is a phase 1 clinical study has been claimed to be complete patient accrual, but there is no data available at present time. And when we search for this kind of the combination, actually we can find there is a study done by the company called Zenith. The Zenith is also using a MET inhibitor from their company called the Zen 3694 in combination with a PARP inhibitor from the Pfizer. They have done just a study in the patient with a triple-negative breast cancer, and this is a dose escalation study followed by a 2-stage study design. And it is actually quite exciting in their dose finding. They found that BET inhibitor, the dose can be 48 milligram of the Zen plus the 0.75 milligram of the PARP inhibitor from the Pfizer. And they show that it's a recommended dose for the phase 2 study. And overall, actually, they have treated 31 patients. And you can see from the left side panel, left side low panel, the overall tumor response rate was 27%, because all these patients do not have the germline BRCA1/2 mutation. Let's suppose this group of patients, their tumor was not so responsive to the PARP inhibitor. So that suggests the combination actually can enhance the PARP inhibitor in patients with a triple-negative breast cancer. In the right side panel, you can see in the subsequential biopsy sample, you can see that BET inhibitor actually really can down-regulate the expression of the DNA repair gene expression, and also can down-regulate expression of the MYC. So that's in the pharmacodynamic study, they show that the downregulation of the DNA repair gene and also the MYC gene expression. So that is important for the future development. And this study also suggests the BET inhibitor maybe soon can be available in the clinical setting, and we can test it in the patient with the cholangiocarcinoma. The other study also very interesting is that the investigator using the ovarian clear cell carcinoma as a model, they try to use one of the cell line with a silence of the ARID1A. So the tumor will have a silence of the ARID1A. They're using this parent cell and also the ARID1A deficient cell to test different kind of the epigenetic inhibitor. And they can find that the EGH2 inhibitor actually can inhibit the growth of the ARID1A deficient ovarian cancer, but for the white type tumor were not affected. When they further tested in the cell line, you can see when the tumor cell was treated with the EGH2 inhibitor, they can decrease the methylation of the H3K27 trimethylation, and also the proliferation of the cell was decreased, and also there's an increase of the apoptosis. The phenomenon was only observed in the tumor with a tumor cell with a ARID1A deficiency, but not the white type. So based on this, I think it's also very exciting that recently there is a drug approval for the EGH2 inhibitor that has been approved for the follicular lymphoma. And from the right side panel, actually, you can see there is a series of experimental in a review article suggests EGH2 inhibitor actually can be synthetically lethal with some of the tumor with the ARID1A mutation, or the other AR that is also the SMARCB1, SMARCA4, and also there is a PBRM1 mutation. So that suggests EGH2 inhibitor actually can target in on the 3 SNP chromatin modulation mutation tumor. And that group of tumor actually is quite a lot. For example, if only targeting on the ARID1A mutation and also PBRM1 mutation, you can see in overall in the Western and also in China, about 30% of the patients have this kind of the genetic alteration. And if the EGH2 inhibitor can be effective, then another 30% of the patient of the cholangiocarcinoma can have another molecular target agent for the treatment. And the other actually is quite interesting. That is a CTK N2A and N2B deletion. I think that is quite common in the cholangiocarcinoma. In a recent publication from the Memorial Sloan Kettering Cancer Center, you can see in their series overall about 15% of the patients have this kind of the genetic alteration. And patients with the CTK2A deletion, actually you can see their clinical outcome was relatively poor as compared to the patient with the white type of the this CTK2A genetic. There is no alteration. The outcome is worse. So you can see for this CTK2A deletion, actually the clinical outcome, the worst are similar to the 53 and also the KRAS mutation patient tumor. Their clinical outcome was significantly inferior to the patient with the white type tumors. And for this kind of the group of patient, I think recently also there is a compound that is targeting on the PRMT5 inhibitor. PRMT5 inhibitor is can be effective to suppress the growth of the CDKN2A and 2B deletion tumor, as well as a MAT2A inhibitor. I think that single pathway is quite similar. So in here, actually, this kind of a genetic alteration is quite common in all kinds of the tumor type. You can see in the left upper panel, in overall, about 15% of the all cancer have this kind of genetic alteration. That is a CDK, N2B, N2A, and also the MTAP deletion. That is an enzyme. And you can see for the patient with the MTAP deletion and also CDKN2A deletion, they are more responsive to the PRMT5 suppression. And this is one of the strategies. And for the PRMT5 inhibitor, I think currently there are several compounds currently in clinical study. But very interesting, only one compound that is from the Amgen, AMG 193, have been selected by the MTAP new cancer type. All the other mainly testing in the hematology malignancy, they did not select the tumor with a MTAP new type. So in the below is a study that has been currently ongoing that started in 2021, October. So I think this is my conclusion that for the emergence of the new compound of epigenetic targeting in clinical setting, practice or clinical trials appear worsening testing in patients with advanced cholangiocarcinoma. For example, what has been presented, BET inhibitor with or without PARP inhibitor for IDH mutated tumor or the c-MYC amplification tumors. EGF2 inhibitor for certain 3 and SNP mutated tumors, and PRMT5 inhibitor for the CDKN2A and 2B homozygous deletion tumor. And I think we can also expect maybe there were more epigenetic inhibitor will come into the clinical trial, and that may be worse for our future testing in advanced cholangiocarcinoma. Thank you for your attention.
Thank you very much, Professor Chen, for being with us early morning in Taiwan. Is there any questions to Professor Chen in the audience? Unfortunately, the other 3 speakers are not with us to answer. So, Professor Chen, if I may ask you a question, so if you are to bet on one of the many tour de force you went through that would be in the clinic next after mutant IDH inhibitors, for example, the BET inhibitors or EZH2, what do you think will be the next step of all the choices that you presented?
I think in the preclinical testing, I think the BET1 inhibitor seems to be more potent as compared to the IDH inhibitor. So if that is also there was some synergism between the BET inhibitor and the PARP inhibitor, I think that there may be a better chance to get a more pronounced tumor response. For example, when they're testing the, I think there is one slide. When they testing the PARP inhibitor with the BET inhibitor with the IDH mutation, IDH inhibitor, actually they show that there is an antagonist effect rather than the synergistic. So maybe the BET plus the PARP inhibitor maybe have a better opportunity. If the safety is okay, I think that was worth testing.
Question from the audience? Hold on, Dr. Chen, we have a question coming.
Yes, please.
I don't know that this is specific to the last session, but it's come up many times today, so I'll ask all the clinical experts here. There have been several talks that mention that IDH1 mutated cholangioma might be more sensitive to PARP inhibition. There's some preclinical research and also BET1 or BAP1 subsets. You would anticipate, if that really holds up, that this group would also be more sensitive to cisplatin. And so I just wanted to ask, do we have any data that these subsets do better with GemCis in first line to sort of support that they are DDR sensitive? And because it's not been my clinical observation. I'm just curious if anyone's seen this.
Well,
Yeah, I think the data is mostly come from the pancreatic cancer. But for the cholangiocarcinoma, I think we are currently trying to analyze our own data. But theoretically, I think the platinum should be more sensitive for the tumor with the HRD. So I think that's still worth testing. And the BET inhibitor seems to can downregulate some of the DNA repair gene expression. And the combination still also worth testing. Yeah.
one additional comment from the Basic Science Symposium speaker earlier today, the researcher studied a variety of different IDH1 mutant cell lines and spheroids, I believe, and PDX models, and did not see any particular sensitivity to PARP inhibition, and followed that up with RAD51 HRD testing in both the PDX as well as some patient samples, and did not recapitulate the finding of HRD in that study. To your question, Mark, about response to GemCis in IDH1, I will draw on the expertise of the crowd. I don't think there was a differential benefit from or differential outcomes in IDH1 mutant patients on clarity prior to entry into the study, but I don't know, Jesper, if you know anything otherwise.
I don't. And if there is no other questions, I would like to close the session and thank all four speakers, particularly the one that was Dr. Chen, that was willing to be on live and answer questions. So thank you, everybody, and we will be closing the session. And
Thank you, and bye-bye.